We'll go ahead and get started here. I'm Davin Quinn. I'm the Vice Chair for Adult Clinical Services for our department, and it's my pleasure to introduce to you today Dr. David Earl, a new member of our faculty, but certainly not new to our department. A very esteemed resident and then a fellow in sleep medicine here with us at UNM, who's going to speaking about restless leg syndrome today. Let me just read you a brief biography of Dr. Earl. He initially came to New Mexico in 2008 to work as a pharmacist for the Indian Health Service in Shiprock. After completion of a one-year pharmacy practice residency, he continued to work in Shiprock until he started medical school here at UNM in 2012. After graduating from medical school in 2016, he stayed here at UNM to complete his psychiatry residency in 2020, and then completed a one-year fellowship in sleep medicine before returning to our department this summer. His professional interests include informatics, quality improvement, and the overlap of sleep medicine and psychiatry. This is such an important area for mental health, behavioral health, sleep. The more we learn about it, the more we understand how important it is to the maintenance of good mental health, as well as how it can contribute to exacerbation of disorders. So we're really, really pleased to have Dr. Earl and his expertise here in our department, and I'm really pleased that he's speaking on restless leg syndrome today, topic that I know I have a lot of questions about myself. So I'm hoping he'll be able to answer them for us. So take it away, Dr. Earl.
Good, thank you. It's good to be back in the department after training and the last presentation of the year. So we'll try to make a good one. Maybe we can finish up a little early if possible, but I always like to allow some time for questions. With that said, I'll try to go ahead and get through the content. I have quite a bit of slides here, and then I have a Christmas gift at the end, particularly for the residents. And so don't let us leave without sharing the Christmas gift that I think will help make life a little easier. Okay, so restless leg syndrome. Couple things. No disclosures, the report, objectives, and we're going to revisit these at the end, but a mineral that's implicated in restless leg syndrome, lab marker, 2 symptoms or more of restless leg syndrome, and then there are 2 or more agents that can be used for treatment. We'll be touching on that. There's a few here at the beginning, just a few general sleep slides that I'm going to just blow through real quickly, just because there's a few things I always like to mention when I'm speaking to a large group of people. Because one thing that we all have in common is we all sleep, or we're all supposed to, and it should be quality. And if it's not, something probably should be done about it. So I do like to put a few little nuggets in there while I have the forum. So one of them is a lot of people have sleep disorder. So how serious a sleep disorder is varies, but particularly those of us working in behavioral health, it's very prevalent. Another thing that is important to always mention, because I know a lot of us burn both ends of the candle, is we need to be having 7 to 9 hours of sleep. That's what the bottom down here is. There are very few outliers on the bell curve distribution that can actually genetically or programmed to get by with less than that. And so that's where a lot of sacrifice is made. If we're not getting 7 to 9 hours of sleep as adults, or allowing us the time to do that, that's going to contribute to a lot of problems both at night and during the day. And we know that people abuse that, and that this is Fitbit data from a few years ago with several million nights worth of data, where basically in the top right here, where people average 6 hours and 38 minutes, and that is under 7 hours, and 22 minutes is significant in sleep. Actually, 8 minutes is significant in sleep. So we know what people are doing because their trackers are telling us. And so getting enough sleep, always important. So I want to mention that. Pills. The thing I want to mention about medication sleep is medication sleep's not necessarily good sleep. We have processes that may be occurring at night. And so the pill is not always the answer, but that's what a lot of people seek or think is a good solution. So just mindful as we get further into this, or you're thinking about just sleep in general, or leg movements during sleep, which we're going to be spending majority of tonight talking about today. Medicines do come with some ill effects. I just want to remind everyone that we have different stages of sleep at night, and movements is what we're mostly going to be talking about today. during REM sleep, dreaming sleep, there should not be movement. Now, we do have a disorder in sleep medicine that is called parasomnia overlap disorder, and that is essentially acting dreams out during dreaming sleep. Everyone else should essentially be paralyzed or have atonia. And so moving around during sleep depends on the stage. But dreaming sleep or REM sleep is considered important for emotional processing. There's some nice literature that shows the utility of that. Just a reminder that we have sleep stages. We don't call stage 4 sleep anymore. We just call it stage 3, but technically it exists if it's greater than 50% delta. But we won't get into that. Sleep deprivation has many effects. And so I just want to reiterate that any sort of kind of sleep related problem, whatever it is, if sleep deprivation is present, it could definitely be a contributor to what's going on. This is very important because we have a lot of medications that affect metabolic at risk, and diabetes is very prevalent in the country. So poor sleep contributes to poorer control of glucose regulation. So I always want to mention that. And I always touch on alcohol when we're talking about sleep, because alcohol is the most used sleep aid. But it is not really a good sleep aid. It does help people fall asleep in an acute use, chronic use, not so much, but it has terrible effects on sleep architecture and fragmentation as it's withdrawing out of the system. And so we really, the less alcohol, the better, with the ideally zero alcohol. And this is a very personal point of mine, so I always mention it whenever I have anybody that's listening, because I lost a very close family member of mine who fell asleep at the wheel. And a lot of accidents, majority of accidents between midnight and 6 in the morning, are related to drowsy driving. It's not always called that. We know that also around 5 in the afternoon is a lull for a lot of people, and that's when a lot of people are commuting. And so I always say, if you're tired, or you're telling someone, do not drive when tired, take a power nap. And a little bit more recent literature that I always like to share because it's so important. It does appear that sleep deprivation is one of the primary drivers of dementing processes. So basically, the trash that needs to be removed from our brain, towels and amyloids and things like that, if we're sleep deprived, we're going to have more accumulation. That is kind of the long and short of that. And so these are some references here. And part of my Christmas gift is going to be showing you guys where to find this slide deck if you want to go back and look at this. We do carry sleep debt. So for those of us that abuse our sleep, it does catch up with us. And anybody that's sleeping more than 2 hours on weekends is not getting enough, allowing themselves enough time to sleep during the week. So we call that insufficient sleep syndrome. Blue light is terrible for anyone that's suffering from insomnia, but if they're sleep deprived enough, they can look at their phone and fall asleep, but it does suppress melatonin release. We really advise avoiding that. So I always like to mention that. Also it's bad for the retina. So ophthalmology is quite passionate about that. Suprachiasmatic processes, with melatonin, because one of the things we talk a lot about that we don't prescribe enough is melatonin. And there are a lot of medical problems that can affect sleep and leg movements, which is what we're about to spend the rest of today talking about. There are numbers of different sleep disorders we treat here. It's not just breathing or leg movements, and some of them have to do with things like abnormal behaviors during sleep that are whole motor movements. Sometimes seizures are related to sleep, and excessive daytime sleepiness issues. And there's a high correlate with mental health, as we all know, so I'm not going to spend any time on that. I always want to plug sleep-related breathing disorders, because a lot of times people are kicking their legs around because they're not getting enough air. Because if the bear's in the cave and you go and you try to start smothering it, it's going to start wrestling around a little bit. Basically, the body's waking up, releasing cortisol, which is terrible. One of the reasons that diabetic control is so horrible in severe sleep apnea. And so sleep apnea is present, depending on what source you look at, 1 to 7 Americans. The real key is a treatable amount of sleep apnea. So there are a lot of people may have it, but may not be something necessarily has to be done about. But there are a lot of people that have moderate severe sleep apnea, don't know it. A lot of them are in our clinics. I started an outpatient clinic in Rio Rancho, or took over. And I don't know how many sleep referrals I've generated already just in the new patients I've been taking on out there. So if you suspect that Periodic limb movements, which is restless leg during sleep, or restless leg syndrome, although we're going to be talking about how to manage that now, or sleep apnea is present, refer them. This is what the treatment looks like, and these are what masks look like, and people get used to them. It's like wearing glasses. I'm a pharmacist, so I always talk about meds. Meds can affect sleep, and they can affect leg movements and breathing and sleep architecture. And so if someone's having sleep issues, a good careful review of what's on their medication list and how it can affect sleep can be of great utility. Okay, restless leg syndrome. So thank you for sitting through the few things I always like to plug. This study here basically shows that restless leg syndrome is more prevalent in females, and that's what the black squares are across the top, and prevalence increases with age. And so prevalence, basically, if you're looking at the two top squares here, is in the neighborhood of 6% in age 16 up for females, and around 2 to 4% age 16 up in males. It does exist in younger, but so be a little bit more mindful of, if it's an older patient, there may be a higher likelihood of RLS. And there is a strong hereditary link with RLS. Here in just a bit, I'm going to be talking about it. It appears to be issues with ferritin crossing into the CNS, or iron transport into the CNS, and so those genetic transport mechanisms, and so there's a high penetrance genetically. And so these are 4 different studies that investigated hereditary RLS. As you can see, it's 50% or higher. These are some of the genes that have been implicated. Now, we do not clinically test for these, because I'll go ahead and say one of the big takeaways today is restless leg syndrome is a clinical diagnosis. There is no objective test that's required. And so there's not just really been seen to be a lot of utility in genetically testing for these polymorphisms, but they are known to be present and associated with the syndrome. Chronic, persistent versus intermittent. So the point of this paper down here at the bottom where the arrow is that chronic persistent restless leg syndrome, also formerly known as Willis-Ekbom disease, is symptoms are present at least twice weekly for a year, and intermittent is less than twice a week. Typically, RLS is 2 or more nights a week if the patient's going to be complaining about it. Mimics. This is somewhat important to, at least for me, to go through. So claudication. There are a lot of vasculopaths, and the key difference between restless leg syndrome and claudication is there's no circadian pattern. Restless leg syndrome is more severe in the evening. Venous stasis, also no circadian pattern. Also, other findings are consistent with venous stasis. Hypotensive akathisia, also no circadian pattern. Painful legs and moving toes syndrome is also no circadian pattern. That is not a real common one that's diagnosed. And then neuropathic pain, peripheral neuropathy, and Vesper's Q have some differences, such as not being relieved by movement or having a stocking leg distribution. Sleep-related leg cramps. Usually that's more of maybe a magnesium or potassium deficiency, and not necessarily just during sleep, but can also have daytime symptoms, particularly if patients on a diuretic, such as a loop diuretic in particular. But palpable tightening of muscle, that will not be present in restless leg syndrome, and it can be alleviated by stretching, not by moving. Positional discomfort, such as staying in a position too long, kind of leg falling asleep, that type of thing, not going to have a circadian pattern, and is relieved by a change of posture. Arthritis is typically confined to a joint, and there may be erythema. Growing pains, more of a pediatric concern, relieved with massage and stretching. Anxiety, so volitional movements of the legs without sensory discomfort. ADHD, volitional foot tapping, and drug-induced akathisia, which we do deal with a fair amount in behavioral health. More of a body rocking, whole body movements and setting of some sort of neuroleptic agent. Okay, so we if during sleep, if the legs are moving, either on EMG tracing or gross movements that we can see on video and EMG, we could refer to that as periodic leg movements of sleep. And 85% of people that are having leg movements during sleep also have restless leg syndrome. And so we call that periodic limb movement disorder because it can fragment sleep. And so they're very closely related to each other. Basically, a simplistic way, and I could probably get in trouble for saying this over here, but periodic limb movement sleep is kind of RLS that's occurring during sleep is a simplistic enough way to think about it. Okay, so we are going to inquire about if a patient has restless leg syndrome or not, and we may want to do something about it. So the urges mnemonic is one of the keys from this whole presentation today. And so urges stands for an urge to move the legs. It is worse with rest, which means getting up will help with symptoms. It's worse in the evening is the E, and it's not secondary to something else. And we're going to be talking about something else because sadly, some of the medications we prescribe, which is one of the reasons that I volunteered this topic to talk about to our department, aggravate restless leg syndrome. And so that's why I think there needs to be this discussion and some increased awareness of the syndrome for those of us in behavioral health. Identifying any current precipitants, I'm going to talk a little bit about that and show a couple algorithms. So basically, iron deficiency is key, and checking that usually will yield helpful information. And I'll talk about what we check. Medications, especially antidepressants, particularly mirtazapine. SAD, it works great. We love it in inpatient. It works fast, but it is probably the worst offender. And then family history and inquiring about that. So we're asking about, we suspect RLS, we kind of go through the urge mnemonic symptoms, and what exactly is it that the patient's explaining? So it's typically going to be like a creepy, crawly, or tingly, should not be sharp pain or something that would be a mimicker. There's typically a 5 to 10% prevalence, could be a little higher in some, and particularly during pregnancy. Fortunately, usually symptoms improve postpartum. It depends on how much blood loss, but usually so. And sometimes are classified as growing pains in pediatrics. There is a scale. We know we love scales. They're very helpful. And so the IRLS, International Restless Leg Scale, is a very helpful tool to administer to the patient or have the patient complete and bring back to next visit, etc. It can be very telling and help with the elucidation of if this is occurring. Okay. And I haven't quite said this yet, but we'll do the poll question first and then talk a little bit about it. But anyone in the chat, if they'd like, what iron study goals are suggested for evaluating restless leg syndrome? We'll just see where we're at kind of baseline here. So I'll take 3 answers in the chat and then I'll move on. Okay, we have a D. I like that answer. Oh, the chat's already entertaining. Thank you. Okay, 3Ds is very, very good. So yes, ferritin level greater than 50 and transferrin saturation greater than 20. Those would be the 2 key markers that we're looking for, which is not blood iron level. And so when we're ordering this, we want to make sure that we're ordering what the labs that we need. And I'll, as a little bonus, as a bow on top of the present that I'll give today, I'll show us some power chart where we can find those labs because we had that built last year. So ferritin greater than 50 is the key, and then transferrin saturation greater than 20. If either one of those are under gold, then we treat with supplemental iron. B12, folate, and thyroid function are also important, so that's part of the panel that we order when we're looking at this. So iron treatment. So we've ascertained that ferritin's below goal or transferrin saturation's below goal. Well, there is injectable iron available. I'm going to talk a little bit about that today, but it's not the most practical to obtain. The Cancer Center does iron infusions, and they can be arranged there. And they also do them at the infusion center at SRMC on the first floor in the medical specialties area. And it is a little easier to get patients in there. And there are a few community places that will do iron infusions. But sometimes there's coverage concerns. So even though iron infusions work great, there's usually some limitations to getting them. So we're usually looking at oral iron in the form of ferrous sulfate or ferrous gluconate, and it only needs to be 325 daily, and usually for 6 to 12 months before repeating, because it's a slow process. It tends to be constipating. More iron per day is just going to be more side effects, not necessarily going to work better. Give with vitamin C is key. I don't want to go too far off on the tangent here, but proton pump inhibitors, omeprazole, pantoprazole, there are a couple others, but those are the most common, essentially obliterate mineral absorption, including iron. They're extremely effective at suppressing acid production. And patient in a lot of cases is better off getting a surgical evaluation for repair of a hiatal hernia or whatever else may be going on than being on long-term proton pump inhibitor. Now, about 15 years ago and prior, we used them ubiquitously and thought they were very safe. But as of the past probably 5 years or so, there's been more and more coming about how they're not particularly safe. And this mineral absorption, calcium being one of them, has been linked with increased risk of osteoporosis in women and men. So not only, so this vitamin C, we need acid in order to absorb minerals. And if a patient's on a proton pump inhibitor, I usually try to get them off or get them to work at their PCP to get them off. Otherwise, they're taking it, not absorbing it. It's already has a long journey, include from the mouth to the CNS is quite an arduous path. So we want to be mindful of that. Oral iron once daily is almost equally effective as twice daily. And that's because hepcidin is one of the, so we talk about the acid hurdle. The next hurdle is hepcidin, which is synthesized by the liver and will decrease the absorption of iron. And sadly, the closer we get to our goal iron indices, the more hepcidin is released. And so the even slower the process becomes, almost on an exponential decline amount. So there's that hurdle that is harder to do something about, and it really just makes this whole process take longer. Fortunately, we have treatments we can offer in the interim while we're trying to get their iron to goal. Major side effects of iron supplementation, typically nausea and constipation. And if iron is not well tolerated, it can be taken with food, but it does decrease absorption. So generally people say, well, take iron with food, but ideally they could take it in the morning on an empty stomach. That'd be a little better. And that's what the guidelines about treatment for RLS recommend. And once every other day may be considered to help with getting the patient to regularly take it. This is a study from one from 2009, one from 2000. So in the left, those who had a baseline ferritin less than 75 who were repleted with iron had statistically significant improvements in their symptom severity as their ferritin increased. Whereas people whose ferritin were over 100 at the outset did not have statistically significant change. And so this is just shining light on the importance of, if the ferritin's low, we want to try to address it. Now, I've been talking a lot about iron, but really the deal here is that the problem is actually increased dopamine production. And most RLS patients actually have sufficient peripheral iron measures. And what is happening is dopamine helps with antagonizing glutamate. So let me show a graphical image of this instead of text form that may help. So this is one of the reasons that dopamine agonists, which I'm going to talk a little bit about, have an augmentation problem. And glutamate, as we all know, is not a very friendly neurotransmitter and is really kind of the key in this process. Turns out that absorption of iron helps downregulate the the um, the glutamate contribution to the restless leg process, and that's why we still focus on iron if we can get it into the patient's brain. But also some of the agents that we now use are actually the first line agents are now pregabalin and gabapentin, or gabapentin and pregabalin. We consider them interchangeable to help with this suppression of the glutamate process. For those of you that are like, okay, I'm glad you care so much about this, but I'm really starting to check out because you're talking really fast and saying a lot of stuff and getting a little sciencey. Here is something that you need to go up and see in Santa Fe, particularly if you're here or just recently moved here. It's a cognition enhancer. This molecule was, I think, investigated in like 1999, never made it to market, but there's a sculpture of it that is in the Santa Fe area. And this is also my favorite website. I think it's the best one that exists on the internet, called Atlas Obscura. If you're traveling anywhere, make sure you check it out because it's got a lot of cool places that you're going to want to see. So anyway, that's for those of you that needed a little bit of entertaining value. Okay, algorithms. So fortunately, there are algorithms for this. So you suspect RLS, you want to try to do something about it. You can offer a gabapentin or pregabalin to help with symptoms. Can't really do anything about decreasing their antidepressant because they really need it. Maybe you try to get them off mirtazapine and onto something else because it might aggravate them less. But if you're supplementing the iron, the algorithm basically is checking iron disease, which I'll show you the order set for, and how to treat, which I've spent time talking about. And if that's not working, then assessment for intravenous iron infusion, or refer to us, and maybe we can work on facilitating that. And this is the intravenous iron algorithm, which we'll forego since it's, as I said, there's some hurdles with it, but it does exist. And this is also part of the same algorithm, but for the diagnosis and assessment, depending on where the ferritin level is. And if we're going to immediately go to oral, which would be my recommendation, is oral ferrous sulfate, or if even the possibility of considering IV iron at the outset. The important thing about this slide, though, is what I've highlighted down here, number 2 at the very bottom in the text, is malabsorption syndrome, inflammatory bowel syndrome, heavy uterine bleeding, rheumatic diseases, and gastric bypasses. It's going to be an even longer road for oral iron supplementation, and we may want to think about intravenous iron first. So if it's a gastric bypass patient with RLS, we may want to try to just go ahead and pursue intravenous iron for them, or someone with significant inflammatory bowel disease or some other malabsorption problem. We do want to check iron indices before prescribing. I know it's over the counter and considered fairly benign, but if someone has hemochromatosis, which is 1 out of 200 people have the gene, we can potentially have some untoward effects. Okay, doing okay on time, good. All right, these are the different intravenous formulations. This is really here for reference. I'm not going to go through this, but typically it's in the neighborhood of 1,000 milligrams. There used to only be one intravenous product available, which is iron dextran, and it would cause a severe reaction. And so people very early in IV iron's lifespan became very avoidant of it, like, oh, this is problematic. But the thing that I want to elaborate for those of you that may have remembered that, if you've been in medicine for a while, is that we now have 5 other products that do not have those problems and are easily tolerated. So when I say IV iron, it's not just iron dextran anymore. Okay, another poll question. I'll take 3 answers, and I think I'm doing good on time, which is good. But all of the following are concerns with the use of dopamine agonist. It'll be ropinirole, pramipexole, except. So I'll take 3 answers in the chat, and I'll also scroll through the chat and see if I missed anything. Oh, whales, that's a good question. We'll talk about that at the end. Okay, concerns with dopamine agonists, ropinirole and pramipexole. Now we prescribe these. So anyone have okay. Take one more answer. Anyone? Okay, Hazel. B. All right. So there you go. Thank you, Dr. Dunkley. It's actually B. So dopamine agonists are not associated with elevating TSH, but they are associated with augmentation. And they are associated with excessive pleasure-seeking behavior, so much so that if you have someone on one, you need to inquire about it and document that you inquired about it. And they are associated with rebound effects upon discontinuation, which are usually transient, and it's rough for the patient, but they'll get it kind of like opiate withdrawal. It's not fatal, but it's uncomfortable. With that said, they are FDA approved, so they're still listed as first line, although clinically we do not use dopamine agonists first line. Now, if you have another reason for a patient to be on pramipexole, well, and they have RLS, well, that they can be helpful, but and they are lower in cost now, except for the rotigotine patch, which is still cost prohibitive and very difficult to get. And if a patient's going to use a dopamine agonist for RLS, fine. Usually a primary care provider will start it, but and they're doing okay on a low dose, then fine. And they're not having any excessive pleasure seeking behavior and things like that, then okay, I'm glad to hear it's working. But cranking the dose up is really a place that you do not want to go. And sadly, we get a lot of people here that in sleep that have been referred because they're on quite high doses and they're experiencing an augmentation phenomena where their symptoms are worsening and starting earlier in the day and sometimes even spread to the upper extremities because they're on so much dopamine agonists. And so one of the first things we do is try to start getting them off of it. This is more of a graphical representation of what the augmentation process looks like, which in simplistic terms is basically worsening of symptoms requiring more dose that helps initially, and then the symptoms worsen again, and they start happening earlier in the day. Levodopa was the worst. Initially, levodopa was investigated for treatment of RLS, but it was very severe at causing augmentation. So it is not recommended whatsoever for this. And it's just a text form one mentioning the paradoxical worsening of symptoms, and they start earlier in the day. Okay. This is if a patient is experiencing augmentation and you're trying to help them with that, and you know that they're going to need to be on less dopamine agonists, there is an algorithm for it. Also includes assessment of iron. Here on the right side, there's directions with how they go about cross tapering or doing a washout. So the algorithm exists if you want to help someone that's experiencing augmentation from a dopamine agonist. Okay. And all right. And just I've touched on excessive pleasure seeking behavior. It can exist in many forms: chain smoking, compulsive shopping, compulsive eating, sexual behaviors. We want to be mindful of that. Okay, GABA analogs. These are more likely this is what we use first line, and what I'm suggesting that you use first line if you're going to treat RLS, which you can do. And so typically gabapentin is where we like to start, and it can take doses up to 3,600, but most patients are fine with doses of 1,800 or less. There is an FDA approved gabapentin product called Horizont, but it's cost prohibitive and difficult to get, so I won't spend much time on it. And in pregabalin, the price actually I think is improved even more. When generics first come out, they're usually still quite expensive until there's a little bit more competition in the market. And then it also depends on how much the molecule costs to synthesize. There's some other aspects there, but pregabalin has become more accessible, we'll say, and the prices come down. It's not quite as cheap as gabapentin, but it's better. And it's typically 100 milligrams 1 to 3 hours before bed. Can go up to a max dose of 450 milligrams. And it's been shown to be at least as effective as pramipexole in head-to-head trial, and it has very low likelihood of worsening symptoms. Opioids actually work very well. And so if patients on an opioid, it's very difficult for them to have RLS. Now, they may have limb movements during sleep because they have pathology in their back. So neuropathy or some sort of spinal disease, we can see a lot of excessive limb movements during sleep, but not so much RLS or restless leg symptoms during the waking hours prior to sleep. There is actually guidelines for the use of codeine or methadone for treatment of refractory RLS, and we do have a handful of folks here that we use those agents for. And then there's also a branded product that is difficult to get. We would usually give someone 5 to 10 milligrams of methadone or 30 milligrams or so of codeine before seeking that. And they essentially have no augmentation risk. Other agents, levodopa-carbidopa has been investigated but not recommended. Cabergoline, dopamine agonist, is really considered a last line, and it does have some other concerns, including fibrosis and cardiac valve risk. It's not something we really ever prescribe in psychiatry, so we'll move past it. Carbamazepine can be helpful but lacks evidence and does not play well with other meds, and so carbamazepine is one to always be mindful of drug interactions with. Also induces its own metabolism, so you may need to increase its own dose within 3 weeks or more after initiation or dose changes. And then clonidine, there's a little bit of evidence about it, but it's not very, it's just considered lacking. Mirtazapine, I do need to sadly beat up on mirtazapine a little bit because it's the worst offender, and essentially a third of patients on mirtazapine will report restless leg syndrome symptoms. And so that's the other reason why I've wanted to bring this talk up today, is because a lot of our meds can aggravate this condition, and we want to try to be mindful of that and help our patients. And it's a pretty straightforward condition to treat. There has been a study of, and this is obviously a sensitive subject for us in behavioral health, but looking at, is there an association of increased suicide risk in those who suffer of RLS? And it's 2.7-fold higher risk, the second bullet here, risk for suicide or self-harm after adjusting for other confounders in RLS patients. So another reason this is an important topic. There are some other alternatives other than medications. We know not all patients are open to an additional pill. And so yoga, there's pilot trial investigating that. It had some benefit, and then aerobic exercise in renal patients. And renal patients, so the prevalence in CKD is exceptionally high. They have several concerns, including vitamin D status and whatnot that they have to deal with, the fund dialysis and things like that. And RLS is one of them. Cannabis. So we know that, a lot of patients are, pretty open-minded about cannabis, and even a lot of providers are, it seems like, but there has been some study into it, a case series from earlier this year, but there were confounders, including use of dopamine agonists, gabapentin, or opioids, which are all evidence-based treatments for RLS. And there was some argument by the authors, is cannabis not still a safer compound than the potential risk of the excessive pleasure seeking from dopamine agonists? And there's a little bit of fat to chew on with that. I'd just like to show this slide again because I just want to remind everyone it's really a glutamate problem that iron helps with by decreasing adenosine. I probably didn't spend quite as much time on this earlier because I was trying to, but central iron deficiency will lead to downregulation of adenosine A1 receptor and less adenosine. Less adenosine allows more glutamate and higher dopamine sensitivity expression. And so that's how we can get the clinical RLS symptoms. And basically, other thing, this is kind of what interferes in the system. So alpha-2 delta ligands, gabapentin, pregabalin, help by counteracting glutamate. Pramiphenol, which is not an agent that's available. It can also help in that pathway. Dopamine agonist also help interfere in this corticostrial area. Dipritamol, which has been investigated and has a little bit of evidence, does help with mitigating some of the effects of downregulation of adenosine receptor. And they're considered emerging treatments as of last year. Okay, so key points. We're now at the end, and we'll do some Q&A, and I've got a couple presents for everyone. Restless leg syndrome is clinical diagnosis. Iron supplementation and/or gabapentin pregabalin are considered first line. And we usually do both. After checking, make sure that we don't have a hemochromatosis concern. Augmentation is common with dopamine agonists. I've really mentioned that more than enough times already. Opioids may be indicated for severe RLS. We do pull those out sometimes. Not comfortable doing that? Well, maybe refer them over here and we can deal with that. If they're already on an opioid, then they're unlikely to have RLS, but they may have other leg issues. The horizon of RLS treatment appears to involve adenosine A1 receptors and striatum. They're responsible for inhibitory control of glutaminergic neurons. And so dipritamol, which is a drug that's been around for a long time, but has cardiovascular effect concerns, has been associated with some significant improvement, but I don't know that that's quite ready for prime time yet. So back to the objectives. So at least one mineral indicated in RLS, as I've mentioned several times, iron, ferritin. Lab markers, ferritin and transferrin saturation are key. At least 2 symptoms, the urge is mnemonic, and at least 2 agents, as I've been mentioning, gabapentin, pregabalin, iron. Okay, thank you. This is my wife and my 2 kiddos. These are references, and we're ready for questions. With that said,
Thank you, Dr. Earl. An amazing sort of tour through a topic that we often don't hear a whole lot about, but we see a lot, I imagine. So I'm really interested to hear what questions people have.
Dr. Earl,
yes,
here. I have a question.
Can you take down the slides, by the way?
Take down the slides, yes.
Well, first, it's great to have you back in the department.
Thank you.
Having a sleep expert like yourself, who's also a pharmacist, is a big plus. Great lecture. Tell me about baclofen. Can it cause restless leg syndrome? The reason why I ask is because there is a patient who I'm treating who's...
Yes. That I am not aware of that, but I cannot speak with enough authority to say no. It's not throughout the learning that I did, baclofen was not implicated as one of the problematic agents. It was mainly antidepressants, things, the serotonergic, noradrenergic, and mirtazapine in particular. And we do see a lot of leg movement issues with patients that are on antidepressants, so including after they fall asleep. I will say that usually patients who are on baclofen, we will see problems with central sleep apnea, and usually they're on it because they have back pathology, and we believe that the back pathology is what is contributing to the leg movements, and the baclofen is trying to mitigate that. But I can follow up with you with a more educated answer as to what their association is, but it's not one of the ones that's considered a prime offender.
Gotcha. Appreciate it. Thank you.
Looks like there's a question in the chat asking about Wellbutrin.
We like Wellbutrin because it doesn't worsen RLS. And so if all other things are equal and you think an RLS is at play and you think Wellbutrin may be an appropriate agent for a patient, then it does have a little bit of dopamine effect. It's not really considered augmenting like a direct dopamine agonist, and so we do like to see patients on that, or if they get, their psychiatrist will consider putting them on Wellbutrin. It is not considered an offender in the RLS literature. It's probably a preferred antidepressant.
Can I have a second question, Dr. Earl?
Mm-hmm.
So for akathisia, we use Inderal. It doesn't have the FDA approval, and there's some data around there. What are the effects of Inderal in restless leg syndrome? And of course, it's used for akathisia caused by antipsychotics, but what does it do to restless leg syndrome?
I don't have 100% certain answer on that one either. It's not one of the ones that's considered a prime offender. One of the main things that we would say as a take home for Inderal in the sleep world is it does have a propensity to worsen nightmares, which can be quite distressing for those who have experienced them. But as far as Inderal and RLS and baclofen and RLS, I'll send you an email about. So I'm not, it's not at the top of my head that they're particularly problematic.
Thank you.
I'd like to keep sort of checking out different medications with you, Dr. Earl. So,
Sure.
you know, when you brought up the glutamate kind of hypothesis or theory around this, it made me wonder about glutamate antagonists like memantine or mantidine. I'm wondering if they have ever been looked at or have any sort of effects. I realize they also are sort of mild dopamine agonists as well, so it can be a little bit murky in terms of what it might be doing and why.
Did not come across it in the literature. I came across things like even clonidine and some of those other agents I mentioned that were cited as lacking evidence, but memantine was not one. I could give it another search though, just to see if there's been anything that is investigated. And it's not in some of our core like textbook reading for it. I know for certain, which is where the majority of the content came from. But I like that question, and it's an intelligent thought to have. So.
Looks like there's a question in the chat about high altitudes in RLS.
High altitude in RLS. That is something, boy, you guys have got some tough ones today. We deal with several other altitude related issues here, chiefly central sleep apnea, which people tend to have different sensitivities to depending on basically their apneic threshold and their CO2 sensitivity in their brainstem. RLS and altitude, once again, is stumping me a little bit, but I'll look into it. And I'll send a department follow-up email. I don't know of any clear associations, but I like that question, Dr. Vicente.
And Dr. Earl, another example of why it's great now to have a sleep expert in the department.
10 papers in PubMed on altitude and RLS. Okay, I'll take a look at that. Just that. Include the words. Okay. I'm phoning a friend over here that's more intelligent. Okay. What's the question here? Great talk from Memorial Sloan, clinical fellow. Frequency, similar symptoms, CL, and they are often described as akathisia and recommendation trial discontinuation. Psychiatrics mentioned hypertensive akathisia as clinical mimic. Yes. Coming on clinical differentiating between antipsychotic-induced akathisia and RLS. So antipsychotic-induced akathisia, probably the more telling thing will be that it will not have like a circadian pattern to it. So RLS is really a problem unless the augmentation is occurring because of a dopamine agonist. Is really a problem in the evening and in the immediate time preceding bed. So usually that hour or two before sleep onset. Whereas akathisia from medication is more likely going to be present, throughout. I think that would be the main discriminator.
Thank you, Dr. Earl. Appreciate sleep medicine Santa.
Sleep medicine Santa.
And this sort of also highlights, I think, kind of the unique skill set that you have in informatics, quality, and quality improvement, as well as sleep. So it's wonderful to see that, and hoping you'll be definitely involved more in these kinds of quality related activities going forward.
Yes, so please consider using the Secure Share Psychiatry residency folder. And if you want access to it, most of the faculty don't have access. Send an IT help ticket, or just send me an email and say, hey, I want to access that folder, and I'll help you out. Excellent. Well, I appreciate everyone's time. Don't see any other questions here. So that's good. Never hesitate to reach out to me. I look forward to seeing a lot of your faces more. I should be here more starting in July. And always available in Tiger or email or text or whatever. So have a good holiday. And once again, thank you for your time.